So with that, I'd like to welcome all of you and to say that we begin with three welcome remarks. Monica Bertinelli, and Rob Califf, and of course, Congressman Foster. Let me start with Monica first. As you know, Monica is the director of NIH, and she was previously director of NCI, a person with great distinction, done huge amount of research in clinical research in cancer, and she's very committed to this issue. She's not able to be with us today because she's giving a commencement speech this morning, and wish her well, but she's going to open our meeting. So Monica, over to you.
Fostering equity in the research ecosystem. Hello, everyone. Thank you for inviting me to help open this important meeting on fostering equity in the research ecosystem. I'm honored to be speaking to you today as the 17th director of the National Institutes of Health. When I got the call asking me to come work at NIH, I did not hesitate to say yes. I've always admired NIH, and I'm thrilled to be in a place where everything we do revolves around a single goal: improving the health of people everywhere. Our job at NIH is clear, if not straightforward. We are here to seek fundamental knowledge about living systems and to apply that knowledge to enhance health for all. At NIH, we take equity very seriously. It's about fairness, and it's one of our overarching goals. I firmly believe that our job is not done when scientific discoveries are made. Our job is only done when all people are living long and healthy lives. Right now, we have an unprecedented opportunity to embrace and increase access to innovation. Fundamental science remains critical, and support for a vast array of laboratory and technology-based research must be sustained. Beyond this, our focus is to make sure that the biological insights identified in laboratories are then pursued in ways that speed their application to improve the circumstances of real people. When the government funds research, it's fair to expect that the entirety of the public will benefit. We agree with others that it's important to think about equity at every step of the innovation process. At NIH, we make it a policy that clinical research must include all relevant populations, including racial and ethnic minority groups, rural residents, people with low incomes, sexual and gender minorities, and other populations who are experiencing health disparities. Everyone should be appropriately represented because inclusivity in research delivers information that is more useful to everyone. NIH is also working hard to make sure the scientific workforce better represents the people of our country, because we expect that the research that such a workforce pursues will more closely represent the issues that are important to people throughout the country. We are supporting community-led research projects that focus on social determinants of health and are testing innovative interventions developed in partnership with local communities. One of my key goals as NIH director is to launch a primary care research network that engages currently underrepresented populations. We need to meet people where they already receive their health care. Using tremendous advances in our data analytic capabilities, paired with innovative study designs, we can conduct clinical trials at the primary care level, addressing questions that are brought to us by providers at the ground level and by the people they serve. The All of Us research program, supported and overseen by NIH, is an excellent model. From its outset, the program has regarded equity as a fundamental principle. The program is building one of the most diverse health databases in history, with the goal of learning how our biology, lifestyle, and environment all affect our health. About 45% of participants in the All of Us cohort are racial and ethnic minorities, and more than 80% are from groups underrepresented in research, including sexual and gender minorities, people with disabilities, and people with low incomes. The goal is to collect data from 1 million Americans and to make this information available anonymously and securely to anyone who agrees to the ground rules for using the data. Similarly, we are going to make the tools of innovation more accessible by expanding the capabilities of the National Library of Medicine. By building out the publicly available data ecosystem, we will promote both innovation and equity. We all know that we are awash in an abundance of data, and that will only increase since federal regulations now require that all NIH-funded researchers share their data publicly. We need to harness all of this research and health data. Along with building a primary care research network, our second main goal for NIH is to build an information ecosystem that engages a wide range of communities. We must integrate data from basic and social science research, public health, and clinical care. Increase the capacity for data hosting. Enable low-cost access to data using open industry data standards, and support broad access to advanced analytics and computational power. I expect that we will employ a federated architecture for data collection and use. And we will support equity in the innovation ecosystem by providing education and workforce development to enable a wide breadth of participation in data science research. The role of NIH is principally to support research, but our research underlies the eventual development of practically every new medical treatment and many new technologies. The fruits of publicly supported research must be broadly accessible, not prohibitively expensive or available to only limited groups. In December, the FDA approved the first gene therapy treatment for sickle cell disease. One of the few treatments is the FDA-approved use of CRISPR-Cas9 gene editing in people. If the treatment works well, it will likely be adapted to treat other monogenic diseases. But it will be important to evaluate the long-term efficacy and safety of CRISPR-based treatments and, if they work well, make them accessible to all who can benefit from them. In January, the Biden-Harris administration announced plans to make gene therapy for sickle cell disease more accessible through a Centers for Medicare and Medicaid Services effort, a framework called the Cell and Gene Therapy Access Model that will allow people who rely on Medicaid to receive sickle cell gene therapy. This is the kind of proactive engagement that is necessary to make sure healthcare innovations are accessible to everyone who needs them. The National Institutes of Health has always been about supporting cutting-edge research. I believe that right now we have more opportunity than ever to embrace and increase access to innovation. In my time at NIH, I will focus on ensuring that our advances in research reach all of the people who need them. Working together with our federal partners and with the healthcare systems, I am hopeful that we can figure out how to make sure that the benefits of research and innovation are shared broadly. Thank you.
Even though she's not here, let's give her a round of applause. That's great. Yeah, what a great way to start. First, with NIH being so committed to the issue of equity. And of course, when I think about NIH in terms of the research it does and the support of research everywhere, I think the key issue of embedding equity into consideration is so important. Next, I'm going to ask Rob Califf, my good friend, to speak. Rob is doing it virtually. And Rob, of course, and I have worked many years together at Duke, and now he's at the FDA as a commissioner. He's done a really great job. And of course, it's so important to consider as products are moving forward towards the market, how do we actually make sure that there's, in fact, equity consideration? So Rob, over to you.
Hey, thanks, Victor. I hope you can hear me okay. This is sort of like the story of my time in Washington. The NIH director gets up and gives a great optimistic picture of the future, and I'm the killjoy who comes along afterwards because the FDA is where the rubber meets the road. So have a brief time. I just want to get across a couple of points, and I really do look forward to the rest of the agenda. I'm going to tune into parts of it, but I am in sort of fireman mode right now as we deal with the avian influenza situation and a few other hot fires that are burning that are keeping me away from being at the meeting in person. So I've looked at the agenda. It's a great agenda. You've got the right people. The goal is phenomenal, but this is a daunting problem. I spent last evening, as Victor did, at dinner with Chris Murray from IHME and Atul Gawande from USAID. And just to sort of set where we are right now, the U.S. currently is 34th in health outcomes in countries in the world. And based on the evidence about trends and our underlying population trajectory, by 2035 we'll be approximately in the mid-60s, which will put us squarely in the bottom half of the moderate income countries. Countries with 1/10 of our incomes are now healthier than we are and are passing us by as if we're in a race, and we're lagging and they're continuing to put more distance between us and them. And yet we lead the world in technology development. And in many ways, the most fun part of my job as I interact with people around the world and in the U.S. is the amazing fountain of technology being developed within the U.S. by our academic institutions and our translational science effort, and of course the phenomenal medical products companies that we have that are pushing technology into the world at a faster and faster pace. And I think the NAM report and the New England Journal article that I read did a good job of making that point, but I don't see any slowing down of this pace. And on my list of worries about the U.S. is not that we'll stop developing innovative technologies for the world. Quite the opposite. I'm very confident, based on what we're seeing in terms of the pipeline of technologies and innovation. But what we are failing in is in the implementation and the equitable hopes for technology. All of this poor health outcome situation that we're seeing has been driven by enormous disparities. And in particular, Chris Murray, and I believe you should look out for this report, they're about to come out with a report about the U.S. and the disparities that are currently being seen within the population. And probably won't surprise anyone that men, particularly African American men and Native Americans and Alaskans are in dire conditions right now in the U.S. despite all this technology, and the trajectory is in a negative direction. So we're doing our job on technology development. We're not doing the job in the area that this meeting is intended to focus on. And while I find the pros in the NAM report and the New England Journal article about it to be wonderful, on the ground the opposite is happening in my view right now. And I refer to Ed Young, who I think writes beautifully about tragic situations, and in an article about the pandemic in the Atlantic, he made the observation, quote, technological solutions drift into society's penthouses, diseases seep into its cracks. And I think that pretty well sums up the experience that I had in the 5 years I spent at Alphabet, where despite enormous efforts to develop user interfaces and other methods to develop technologies that reached people of all types, particularly in the U.S., it's the wealthy and the highly educated who immediately latch on to useful technology and make the best of it, with many others left behind. Now, I think the word ecosystem is the right term. And part of that is a recognition on my part of the limits that I see as I'm in a federal agency, which is often imbued with magical powers by those on the outside who believe the FDA can simply give an order and things will happen. But the fact is, the FDA operates within a framework which is driven by the laws, much like referees in a sporting event where the rule book is not written by the referees, it's written by the owners, in our case, the U.S. Congress, and with significant input from the executive branch. And so this 2 sessions this afternoon on, quote, building an equitable innovation ecosystem, unquote, I'm going to be watching very carefully. And the question is it possible to build an equitable ecosystem in the research arena and the technology arena when it's operating within a healthcare delivery system which is built structurally to be inequitable? And I'll just give you examples that are before us today quickly in closing that raise this question big time, in my opinion. The first is one that I'm working on a bit today, diversity in clinical trials. We've made a lot of progress on more diverse clinical trials, but the field is moving on to asking the question, do we have a representative sample of the entire United States with enough people in each category to draw inferences about whether the treatment effects are the same in different kinds of people? While at the same time, there's tremendous pressure and written into the law to minimize the size of clinical trials. These two things, I'm sorry to say, are not compatible. It's impossible to have a totally diverse population in a clinical trial if the trials are small. I'll just point to sickle cell disease, which it's great that Monica brought this up. 91 patients form the basis for the gene editing application in sickle cell disease. And under the law, over half of our approvals are accelerated now, which by design means a small sample size. And so much work to do on diversity, but we have to resolve this issue of the divergence in the financial pressures on the industry and the desire to get things on the market quickly with the need to have trials that are large enough to actually have representative populations. The second example, and I don't need to go into this in detail, is the GLP-1 drug situation. Here we have, a new report yesterday, 4-year follow-up, really tremendous outcomes now, not just weight loss, but cardiovascular events and many other negative outcomes impacted in a favorable way. Who's getting the GLP-1 drugs in the U.S. today? The wealthy and the well-to-do and the highly educated, far and away. The people that need them the most, arguably, don't have access to GLP-1 drugs in this situation of shortages. And of course, back to sickle cell disease, how we're going to make a treatment that costs $4 million per dose or something in that range, which is what we're currently seeing for these drugs, despite our pilot programs with CMS. It's hard to imagine, unless we make major changes in the structure of our healthcare system, that this is going to work. So I'll close with 2 notes of trying to be optimistic. I know Monica wins the popularity contest here and not me, given what I'm saying. But I'm hopeful that we can walk and chew gum at the same time, or an analogy that came up already this morning in a different context is maybe we can have both the belt and the suspenders on our health outcomes. And if we could simply do things with technology that improved our ability to deliver primary care with healthcare as a right, including home-based care, this would make a tremendous difference. Both Chris Murray and Atul Gawande agreed that what's differentiating these low-income countries that have better health than the United States is the availability of primary care in the neighborhood, including people going into the homes who are friends who live nearby and can do the simple things, not the high-tech things. But we have the ability with our technology, and we have a new program at FDA attempting to build a platform that will integrate technology at home that might make this very basic element of healthcare possible without disrupting the investments that are needed in the science and technology that you all are thinking about today. And then finally, I do think AI holds tremendous promise to break down the barriers that are separating us right now. It could, and currently is working very much in the opposite direction because of segmentation of populations and advertising and the way it works. But I hope you all can figure this out, figure out how to make information, as Monica said, available and pertinent to the whole population, and deliver it in a way which is not so expensive that only the wealthy and highly educated have access. Thanks, and again, I look forward to hearing about the meeting.
Thank you, Rob. Yeah, Rob always calls it as he sees it. I've known him for a long time. And I'm glad he said all those things because what he says is absolutely true. And he asked me last night, what do we want to do with all this? I think at the end of the day, we're going to talk about how we're going to move this thing forward. As been said, we've been working on this for almost 4 years. It's time to really put some of the ideas to action. That's what we hope to get out of this meeting. So next is my great pleasure to welcome Representative Bill Foster from Illinois. Thank you very much, Bill, for being here. So he has spent 2 decades, first as a high-energy particle physicist, as probably the only scientist, certainly physicist in the Congress. He was at Fermi National Accelerator Laboratory, where he was a member of the team that discovered the top quark. You're going to have to tell us what that is. But anyway, when he's elected to Congress 2008, he's really been totally, shall we say, dedicated to bring science and now the issue of equity to decisions made in Congress. He really brings a critical scientific perspective to policy in Washington. We're so glad, he's certainly visible at the Academy. He's involved in many of our activities. For me, I certainly remember many conversations we had on the areas of genome editing and CRISPR, in which you were actively participating. So please come up and give us your wisdom. Welcome. Thank you.
Thanks so much. And I guess it's my job to take even the next step down in the descent toward reality in our discussion. I want to thank Monica and Rob about that, for stealing all of my talking points that I was prepared to give here. But it's always an interesting challenge for my staff to get me to stick to any prepared remarks on this. First off, I really want to thank the National Academy and all of you here. This is a big deal. I'm best known as being, the science guy in Congress, but I'm also the son of a civil rights lawyer. My dad wrote a lot of the enforcement language behind the Civil Rights Act of 1964. Back several generations ago, my great-great-great-grandfather during the Civil War was put in charge of one of the first regiments of freed slaves, where he promptly found himself threatened with court-martial for insisting that the freed slaves under his command be given the same food rations as the white soldiers. So you can see I'm a troublemaker from way back. It just, this is, I guess it was almost 10 years ago, right at the birth of CRISPR, when we were having hearings in the Science Committee with Jennifer Doudna and others, talking about what this was going to mean. And then as a result of those hearings, I guess I was invited to give the kickoff speech to the National Academy's Human Germline Editing set of international conferences, which were a big deal, and especially the second one for not so good reasons. My apologies for not keeping that one under control. But at that conference, I think I had a look recently at my speech back then, and one of the main points I made was that, it's important that the public have a good first view of this incredible technology, CRISPR, and my specific suggestion was all of you industry participants who were there, go home and start working on sickle cell. And I've been told by some of them that it was after that speech that some of them said, okay, we are going to do that. And so I've been watching, sort of, thrilled at the progression towards being a functional $4 million is currently the number. Wow. We were hoping for $500,000, and the problem is if you take $500,000 in quantity, 100,000 sufferers, that's a huge chunk of change, as they say. But I always felt a little worried about focusing on the CRISPR and the bone marrow transplant scenario, because that is something that will never deploy in the third world, where a lot of the sufferers are. And so maybe we should have spent more effort working on small molecules that can at least provide a treatment that's an affordable treatment. And so, that's an example of what Rob was talking about there. We just have to think really carefully about what we can accomplish in a budget-constrained scenario, and the essential tension between everything we'd like to do with equity and for example, large clinical trials versus the financial limits there and the scope of what you can accomplish overall. So, I thank you for thinking hard about this stuff. It is not easy. During the COVID crisis, I was on the COVID Select Committee to look at our response there, and we were wrestling with all these same problems. One of my conclusions from that was that the biggest disparity of all is the disparity in access to information. This is, and I think that's going to change, and it's going to change for the better from AI. Soon we are all going to have in our pockets, the best team of legal advisors that's ever been assembled. Because you're going to have an AI that has looked at every court case, the arguments that won and lost, and so if you get in a legal fight with a billionaire, it's going to be a level playing field, and this will have a tremendous leveling effect. Same true of medicine. If you get cancer, you're going to have the best team of oncologists ever assembled that sees every case and that's comparable to yours and can give you better advice. And so this is going to be transformative. And it relates to this incredible fact of the digital economy, that if you are a billionaire, you cannot get a better cell phone. Just think about that for a moment. Why is that? If you're a billionaire, you cannot get a better Wikipedia. When I was a kid, if you're wealthy, your parents got an Encyclopedia Britannica. Not so wealthy, you got a World Book or nothing at all. And that has disappeared with Wikipedia. And it's actually a testament to the benevolence of the human species that we've got people to contribute for free to something like Wikipedia. If we can arrange the same thing to happen in AI and its application, then I think we will have accomplished something tremendously, particularly for those at the bottom rungs of the ladder in our society. There will be a disproportionate positive impact. So we should not do anything that will slow down the things that we are going to be doing to reduce the disparities in access to information. That's going to be, I think, crucial. And the truth of the matter is, it's going to be essential. The internet is so vast and our brains are so small. We simply need an AI to stand between us and the internet to decide what tiny fraction of all the information out there we will focus our attention to. And the difficulty happens when that AI does not have our best interests at heart. If that AI is the Google search engine, then it works for the advertisers on Google. If it is the Facebook search engine, it's maximizing Facebook profits by getting everyone in a fight. And so it's important that when people go for medical advice, they get something that actually has their best interests at heart. And so I think our challenge in Congress is to make an AI that's on your side. And that is going to be very often at cross purposes to the commercial tensions. We get tremendous benefit out of the free market and the commercial involvement in technology development. But if we have a purely profit-based system, there's a big problem there. And so and that's something that all of you in that room are going to have to navigate. We cannot kill the goose that is laying golden eggs at an unprecedented rate, but we have to have some guidelines for the goose's behavior. So I just want to thank you all for being part of this really important discussion. And when you figure it out, please let me know.
Thank you very, very much. Yes, well, you can be helping us figure this one out. I think I've said this to others about what I think about this area, and it's not a great analogy, but I do think about human subject protection, the Belmont report, and how Congress actually took this on and say, let's just make sure we put some good practices around this. From there, as you know, it was limited only in the context of government agencies and government funded, and now it's a norm. So I think Congress can do a lot. And Bill, we hope that you will help us being a champion. When we think about how to advance this through the system, how to make it actually a norm, that equity becomes a norm in many things that we do. So thank you very much. Now, before I introduce our keynote, I do want to acknowledge the team that's put a lot of time into work, in particular, Melissa Leitner, wave to us. Melissa is my special assistant. She's taken on this project with a passion. And she's really been the major driving force of organizing this meeting. And as we're putting this together, we say, well, here's another person we can include. Here's another one. We're going to have to figure out how big the panels are, right? But she's terrific. And of course, Katie Bowman. Katie, as many of you know, this is her field. And so we're so glad that, in fact, she's working with us. But we also have Emily Schambach in the back. Emily. And of course, Kimber Bogart, who's not here right now.